very medical system incorporation, and to continue our support for FARO webinars from IROS. Thank you very much. And yeah, let's start our webinars today. Thank you.
Thank you, Dr. Imjai. I'll just share my screen to give introduction to the webinar and the timeline that we're looking at. So I hope you all can see this. So like what Dr. Imjai mentioned, we are talking about radiotherapy of brain tumors. We will start off with Dr. Kevin's talk, which will be for about 15 minutes. Then we'll move on to Dr. Brendan's talk, looking at the NCCS brain proton experience, which is also a very timely topic because just of last year, we have actually 3 proton centers in our country which has gone operational. And the last part of the hour, we will take comments and questions and have a lively discussion. So I'd like to invite the participants to use the Q&A box to ask your questions during the talk itself. And at the end of the webinar, we will have perhaps an opportunity for you to unmute yourself and ask your questions live. But since I have a captive audience, I just want to take another couple of minutes to introduce the Singapore Radiological Society. So it is made up of both of diagnostic radiologists, interventional radiologists, nuclear medicine, as well as radiation oncologists. And actually, for the first time in many years, we have a radiation oncologist serving as the president. He's none other than Associate Professor Francis Ho, who's a senior consultant at NCCS and also my head of department. I serve as the subsection chair for the radiation oncology subsection. Similar to Francis, I work at NCCS and my interest is neuro-oncology, and I also serve as the chair of the brain and spine cancer program for NCCS. And together with me, our subsection committee members includes members both from the private sector and public sector. And also, we are also grooming young physicians to take over our roles as we grow older. And also our FARO reps from Singapore, a particular mention to the Education and Training Committee, Dr. Ivy Ng and Dr. Gail Chua, who helped to put this program together, as well as Dr. Koh Wee Yao, who was part of the previous Education Committee. Just a special mention, we are organizing the Asian Society for Neuro-Oncology meeting later this year in Singapore in August, so everyone is welcome. And the website is listed here. And actually the chair for the conference is none other than Kevin Chua, who will actually give a bit more information at the end of the session. So without further delay, I'd like to introduce Kevin. So Kevin is a senior consultant in the Department of Radiation Oncology at the National Cancer Centre Singapore. His interests are in neuro-oncology as well as in lung cancers. He's a clinician investigator in the Precision Radiation Oncology program. He got his undergrad medical degree in King's College London and has gone on to complete fellowships in UCL in neuro-oncology and neurosurgery. He also serves as the lead for the stereotactic radiosurgery service in his hospital. And I would like to hand the stage to Kevin to give us his talk on novel radiotherapy approaches for brain metastasis. Kevin.
Thanks, Bala. Thanks for the introduction. And thanks to FARO for organizing this webinar and inviting us to speak on this very exciting topics today. So my task today is to take everyone through brain metastases management, in the current paradigm, right, of systemic therapy and new technologies that we have access to. So without further ado, I'm just going to make sure that everyone can see my screen. Okay.
Yep, it's fine.
All right, sure. So let's get started. These are my disclosures. Nothing particularly relevant to the talk today. So incidence of brain mets. So essentially, I think brain metastases is really one of the key pillars of radiation oncology practice, and it's something that we deal with, day to day. And in fact, if you look at the incidence of brain mets across all histologies, and you compare that to some of the other common tumor types that we deal with, and if you pull all these brain metastases incidents together, then you realize that actually brain mets is it's a big problem, right? And it's something that it affects not just us as a radiation oncologist, but also the multidisciplinary practice. In fact, if you look at the NCCN guidelines and the recommendations for screening, NCCN really only recommends screening for specific tumor types, and there are a lot of other non-high-risk histologies that are actually not picked up routinely, and so it is possible that the incidence of brain mets is even higher than what is reported currently. And so over here, it's some data from the Chia database on the right. And what I've done is essentially just highlighted some of the key tumor types that are at risk. And over here, it's quite helpful because they've broken it up by subtypes as well. And so if you look at breast over here, so basically there are two columns over here. One is incidence proportion among the entire cohort. So they basically look at the incidence of new brain metastases diagnoses, and they divide it by the primary histology incidence. The last column on the right is divided amongst the incidence of patients who actually have metastatic disease or extracranial disease. And essentially, you can see over here that already you can see that patients at stage 4 are at higher risk of developing brain metastases. And there are specific tumor types which are at higher risk as well. And even within specific tumor types, for instance, in the breast, you can see that essentially the triple negative and the HER2 positive patients may be at slightly increased risk. GIT for gastrointestinal esophagus I've highlighted because it's also among the highest. For gastrourology, for genital urinary renal as one of the higher brain mets incidents as well. For the lung, you can see the spread across different tumor types with adenocarcinoma, small cell, and NOS is actually not otherwise specified. So basically, these are some of the at-risk histologies, and later on I'll show you some data which dives even deeper, breaking down into the molecular subtypes as well. So brain mets is a problem, and it's a problem that we have to deal with. And so what I'm going to do over the next couple of minutes, just take you through some of the main radiation modalities and give you a sense of essentially where things are shifting towards and some of the impending trials that are going to read out that will help guide our practice. So, first off, whole brain radiotherapy, this is, easily accessible even to many parts of our region. And essentially, the point I wanted to make here is whole brain radiotherapy has a role, and whole brain radiotherapy actually provides a very good overall intracranial disease control, right? And that, look, depending on the studies, can be between 60 to 70%. The problem, and really, so the role of whole brain radiotherapy was really sort of defined with this seminal paper by Petrel, and this is many years ago. But essentially, you compared patients who had either surgery alone or surgery plus whole brain RT, and it showed that essentially your intracranial tumor control was improved, and essentially neurologic death was decreased as well. So there is a role for whole brain, and this is pretty well defined. The problem with whole brain radiotherapy is really that of neurocognitive impact, and this is something that we see day to day, especially when treating elderly patients as well, or patients with poor performance status. And so, if you look across the different studies, there is a huge variation. I think a lot of that has to do with how neurocognitive measures or outcomes are being reported, but there is enough data out there, and which is supported by clinical experience, that suggests that essentially with whole brain radiotherapy, we do have to grapple with the neurocognitive impairment, and basically this is long lasting. And because of that, people have started looking at different ways to mitigate some of these neurocognitive deficits. There is a very small study which looked at essentially the addition of memantine to whole brain radiotherapy, and in this particular study, they basically, the way that memantine was delivered was that for the first 4 weeks there was this gradual dose escalation, and then basically from week 4 to week 24, essentially there was a constant dose of 10 milligrams twice a day. And essentially what they found was that with this with the combination of memantine to whole brain radiotherapy, there was an improvement for some of the neurocognitive outcomes. And basically, the primary, even though the primary endpoint was not positive in the end, and it was just a trend towards improved neurocognitive outcomes, there were some other measures which essentially supported the authors coming to this conclusion. There were some caveats to this study. Of course, one being that when it got to the primary endpoint, a good number of patients had already fallen out, because essentially this was a patient that was of a slightly the outcomes were going to be poorer. And so at the primary endpoint mark, essentially the statistical power had only dropped to about 35%. And so because of that, there's probably enough evidence to suggest that there is a role. Some patients may potentially benefit. And if you're going to consider giving whole brain radiotherapy, essentially this is one measure that you can essentially introduce to mitigate some of the neurocognitive impairment. More recently, people have started looking at hippocampal sparing whole brain radiotherapy, and essentially, a lot of it revolves around the fact that essentially this neural stem cell, the hippocampi, essentially houses the neural stem cell niches, and essentially by and these are essentially very, very sensitive to radiation, and by protecting these neural stem cell niches, essentially you can help improve some of the neurocognitive deficits that people will experience with whole brain radiotherapy. There was a randomized phase 3 trial, which essentially demonstrated improvement with hippocampal avoidance whole brain radiotherapy. Over here, they found that essentially you started to get this separation in terms of neurocognitive outcomes, which began at around 3 to 4 months and persisted throughout. And they felt that a lot of this cognitive function preservation was basically driven by reduced deterioration in learning and memory at 6 months and executive function at 4 months. You can see over here the multivariate analysis. Obviously, the treatment arm turned out to be positive on statistically significant on multivariate analysis. The other thing that came out was age, and essentially patients who are older than 61, patients who are older than 60, essentially were at risk of neurocognitive impairment following whole brain radiotherapy. And so, the thing to note is that basically hippocampal sparing is one of the ways that we can mitigate some of the neural deficits associated with whole brain radiotherapy. The thing to point out is also that in this study, basically all patients on top of hippocampal avoidance also received Momentin as well. And so if you were to consider hippocampal avoidance, then essentially Momentin is by level 1 evidence according to this protocol would be necessary. Just a quick final word about whole brain radiotherapy. There are patients according to the Quartz trial that essentially will not benefit from the benefit of whole brain radiotherapy. So this was a study that was performed in a group of patients who were deemed not, either not resectable or not amenable to radiosurgery. And so what I've done is I've essentially highlighted some of the key characteristics of these patients. Essentially 80% were class 2 and above, RPA class 2 and above, 63% had uncontrolled metastases, and group 40% had poor performance status. And within these patients, they found that essentially whole brain radiotherapy did not improve survival compared to just best supportive care with steroids as well. So essentially there is a role for whole brain radiotherapy. There are ways that we can mitigate some of the neurocognitive deficits associated with whole brain radiotherapy, but really when it comes to patients with poor performance status, with uncontrolled metastases, or essentially older patients, then potentially whole brain radiotherapy is something that we really need to think very hard about before offering treatment. And so, this is just a quick run through regarding the role of whole brain radiotherapy. The next up, I'm just going to take you through some of the more advanced techniques. So stereotactic radiosurgery, I'm sure needs no introduction. Essentially, what it does is it applies precision radiotherapy techniques with onboard imaging, robotic couch to essentially correct for and allow us to deliver radiotherapy with pinpoint accuracy. And so in many of the traditional radiosurgery systems, we're now looking at precision systems that are 0.5 millimeter accurate and even beyond, right? And when it comes to stereotactic radiosurgery, that's an umbrella term. Essentially, broadly speaking, you have single fraction radiosurgery, you have multi-fractions, radiosurgery. I would say that right now, essentially, there is some debate as to which is better. Certainly, if you look at the local control rates for single fraction radiosurgery, it's pretty promising and it's pretty good across the board. When it comes to large brain mets, though, and going by the RTOG 9005 escalation protocol, tumors that are between 2 to 3 centimeters, essentially, the recommended dose is about 15 gray. Those that are greater than 3 centimeters is about 12 gray. And so, because of that limited single fraction doses, and what people have done is essentially tried to escalate the doses, give a higher biological effective dose by essentially trying to mitigate by essentially fractionating. And so over here there's a table over here, and you can see over here 15 grays is single fraction, over here, the authors has basically worked out the biological effective dose with alpha beta 10 representing the tumor that the dose that the tumor received. On the x-axis, that's the biological effective dose by alpha beta of 2, so that's normal tissue. And you can see over here that with hypofraction, essentially you can deliver a slightly higher biological effective dose with less dose to the normal tissue as well. And so basically with multiple fractions, essentially that allows us to basically strike a better balance and provide improved tumor control. And so there is some data that suggests that multi-fraction radiosurgery may be somewhat better compared to single fraction radiosurgery, especially with large brain metastases. So this is a retrospective study that was published in Rate Journal not too long ago, and essentially you can see over here that for this it was a retrospective review, and it did propensity matching and compared 3 fractions of 9 gray versus a single fraction, and they found that essentially there was a slightly improved local control with multiple fractions. And there was also improved radiation necrosis rate as well. There are currently ongoing studies, including randomized trials that are looking at this question. But I think certainly when it comes to large brain metastases, our institutional practice has really been to deliver multiple fractions of hypofractionated radiosurgery. Of course, with more clinical experience, we also now are starting to develop tools and dosimetric constraints that help us guide a way we try and mitigate some of this radiation, these rates of radiation necrosis. And so this is a study was published by the Sunnybrooks group. And essentially what they have demonstrated here is that if you look at essentially some of the dosimetric constraints, if you look at brain minus cavity or brain minus gross tumor, essentially if you look at sort of keeping the volume keeping the volume receiving 30 gray to less than 10.5 cc's, basically you can try and reduce the rate of symptomatic radiation necrosis. And so if you are doing a hypofractional radiosurgery, these constraints will be very helpful to guide your practice. There are a lot of constraints that are listed in those constraint guidelines as well. And so I urge you to refer to those, and over there they have listed those constraints for 3 fractions, 5 fractions, 2 fractions, and so on and so forth. And so we know that there's a role for stereotactic radiosurgery, and a lot of it really started when people started looking at studies comparing radiosurgery for 1 to 3 metastases versus radiosurgery plus whole brain radiotherapy. And in many of these studies, they found that essentially with the addition of whole brain radiotherapy, there was improved overall. So the whole brain radiotherapy basically improved overall intracranial disease control, but that really came at no difference in overall survival. And in fact, if you compare the neurocognitive outcomes between radiosurgery versus radiosurgery plus whole brain radiotherapy, there was some less cognitive decline with radiosurgery alone. And because of this, when it comes to 1 to 3 brain metastases or patients with limited brain metastases, it became standard practice to offer patients stereotactic radiosurgery. Right. Moving on, since then, people have started looking at stereotactic radiosurgery for more brain metastases. This is a seminal work from the Japanese group using the gamma knife platform. So in this paper, Dr. Yamamoto essentially looked at the gamma knife outcomes for 1 brain metastases, 2 to 4, 5 to 10, and what they found was that essentially, of course, with the solitary brain metastases, the outcomes were better. But between 2 to 4 versus 5 to 10, there was no real difference between these 2 groups. And there was certainly no overall survival benefit. And when they compared the long-term neurocognitive outcomes between essentially patients receiving 2 to 4 patients receiving radiosurgery for 2 to 4 brain metastases versus 5 to 10, and they measured this using the mini-mental state, there was no difference as well. And so 1 to 3, there is good randomized data to support stereotactic radiosurgery. For patients with 4 or more brain metastases, radiosurgery can be an option if delivered safely. Now, of course, the question then remains, what is the role for patients with 4 brain metastases? This is an area where we're still lacking randomized data. So there are ongoing studies right now that's comparing radiosurgery to multiple brain mets versus hippocampal sparing or hippocampal avoidance whole brain radiotherapy. Over here are some of the studies which I've listed out that are still undergoing accrual. You can see over here the number of brain metastases are different between the studies, range from basically 4 to 15 or anything that is more than 5 brain metastases. The exclusion criteria is somewhat different, but essentially consistent with a lot of our clinical practice. And the primary endpoints range from essentially just looking purely at quality life outcomes at 6 months to intracranial PFS, overall survival, and cognitive outcomes. And so we look forward to some of these that will help us guide. The thing to know is also that a lot of these studies are done across multiple different histologies. So it could be that when these studies finally read out, we will have to put them into context of all the different systemic therapy that's out there and all the different multidisciplinary considerations as well. And so we look forward to some of these data reading out. Again, this is, I'm running short on time right now, but essentially, for patients that have undergone resection, the traditional practice is to offer whole brain radiotherapy. Again, we have randomized data right now, which essentially compared post-op cavity versus post-op whole brain radiotherapy. Just a few things to highlight. If you look at the outcomes for post-op cavity irradiation, the local control at the surgical bed is actually much lower, and this was statistically significant compared to whole brain radiotherapy. There are few, but in the end, the study was positive because of improved or better neurocognitive outcomes. There are a few reasons for this lower control rate. One possibility is that the contouring, there's huge variability across the different institutions, and definitely when it comes to defining the cavity, with a post-op MRI, it's not always straightforward, and where you think it's its enhancement could really be just post-surgical change. And often, in clinical practice, what we do is we essentially give larger margins to account for some of this contouring uncertainty. And so this is potentially one of the reasons why the local control rate is not quite as good, and one of the reasons why essentially some of these efforts, like having a consensus approach to defining this post-op cavity for radiosurgery has subsequently come out to guide our practice. There are some benefits to comparing. There are some purported benefits between pre-op SRS versus post-op SRS, and this is some of this is certainly one of the areas where there's a lot of excitement is building up. I think there are a few good reasons for it. One, with pre-op SRS, essentially you have a very well-defined target. And essentially, the idea is that you'll be radiating less normal brain tissue as well. And there's also a thought that essentially, if you deliver radiosurgery prior to surgery, essentially some of these tumor cells could be temporarily at least defunctioned, and so the risk of pachymeningeal seeding, which is sequelae post-op, could be mitigated. And so, for that reason, people have started looking at some of these retrospective studies comparing the two. Some of these small series do suggest that there is a benefit with pre-op radiosurgery compared to post-op cavity irradiation. And so there are now a whole series of trials that are in process. You can see over here, there's some variation, but commonly the radiosurgery is delivered, anytime from 1 to 4 weeks of surgery. And hopefully with these, we will have a clear idea of essentially what the practice should be moving forward for patients that will need surgery. Just for a quick word, small cell is traditionally an area which we have prescribed whole brain radiotherapy for, in part because of the large or the high risk of distant cranial metastases. There was this multi-institutional retrospective review which essentially looked at outcomes with institutions that have prescribed stereotactic radiosurgery alone for small cell brain metastases. And what was interesting was that, yes, they found that the distant intracranial relapse rates were significantly higher within this group of small cell lung cancer patients, but patients who received radiosurgery alone, there was no difference in overall survival. And for patients certainly with limited metastases, or patients that I would say that we traditionally think of small cell lung cancer patients as having limited options, have not doing so well, but prognostically we can see that these patients are also shifting as well with new targets that are coming in, with new ADCs and immunotherapy. And so these days I find myself more inclined to offer radiosurgery for these patients as well. But of course, with the caveat that essentially patients must be prepared for subsequently receiving multiple treatments for high rates of distant cranial failures. Just a very quick note, within the Asian context, we have patients, we do see that our adenocarcinoma patients are when it comes to lung adenocarcinoma patients, are somewhat different compared to Caucasian populations. A lot of these different molecular subtypes all have different propensities for brain metastases. So this was a very interesting paper that looked at the different molecular subtypes, and you can see over here the red line is really the wild type incidence of brain metastases, and you can see that there are some tumor types which essentially report higher rate of brain metastases. When it comes to these patients, there are a lot of new novel agents that are out there. They have good CNS penetration, and so the question always comes back, right? What is the optimal sequencing strategy for patients that are asymptomatic? What is the optimal approach? Certainly, I think these patients all have to be discussed in a multidisciplinary tumor board, because sometimes these conversations are not always straightforward. When it comes to the optimal sequencing strategy, we do know that essentially for well-selected patient population, especially those with limited metastases, there may be a role for upfront radiosurgery on top of some of these, even CNS penetrating tyrosine kinase inhibitors. And I think in the interest of time, all I'll just say is that I think this is a space which really remains to be defined. We do have the OUTRUN study, which is run and conceived out of NUH, that will hopefully give us some guidance in terms of what the optimal sequencing strategy will be. Right. So finally, I thought I'll just end off just very quickly by just taking you through a quick run through of the ESCO/SNOS Astro brain metastases guidelines. Again, surgery for large brain metastases, especially when there's the need for tissue diagnosis. For asymptomatic brain metastases, I think in the context of a multidisciplinary discussion, you can potentially defer local treatment if there are good CNS penetrating options out there, especially those with well-documented CNS response rates. Certainly when it comes to patients with poor prognostic status, old patients with, essentially poor KPS, essentially I would think very hard before offering whole brain radiotherapy. For patients with limited brain metastases, stereotactic radiosurgery is an option. For patients with limited brain metastases that have undergone surgery, certainly cavity irradiation is associated with improved neurocognitive outcomes. And for patients with a larger number of brain metastases, essentially the debate is still out there whether it's whole brain radiotherapy or stereotactic radiosurgery. I think if you have that discussion with patients and they're mindful of the risk of subsequent relapses and need for subsequent treatments, you can certainly offer radiosurgery. If you do offer whole brain radiotherapy, there are mitigating strategies out there, whether it's memantine or hippocampal avoidance. And in the context of patients who are planned for surgery, there is the role currently is being defined for post-op radiotherapy. But if you can, essentially pre-op radiosurgery is a potential option as well, and there are some benefits to that. And so this is the last slide of my talk. I'll just very quickly, Bala mentioned the ESNO annual meeting earlier. So this is the annual meeting for the Asian Society for Neuro-Oncology, and this year we're going to have it in Singapore from the 16th to 18th of August. We have an exciting program that's lined up. It starts off with pre-conference workshops. We have the neuropathology workshop, which is essentially designed by the Asian Oceanian Society for Neuropathology, and is meant to help educate everyone on the different different shifts in terms of the WHO CNS classifications. We have a neurosurgery cadaveric workshop. We have a translational neuro-oncology workshop that is held in conjunction with Duke NUS. And also there is a ESNO clinical trials workshop. All these pre-conference workshops are free, and I encourage everyone to apply. For the main program, we have an exciting lineup. We have 2 plenary sessions which revolve around IDH mutated lower grade gliomas, high grade gliomas. We have essentially breakout sessions for neurosurgery, radiation oncology, pediatric oncology, plenary sessions focused on spine, brain metastases, and clinical trials. And so the abstract deadline is in 2 weeks' time, and we urge everyone to join us in Singapore. And with that, I thank you for your time.
Thanks, Kevin. That was a great talk summarizing all the important evidence that we need to know, but also touching on the new novel techniques and novel evidence that is emerging. And also thanks for introducing the ESNO meeting to the audience. We do urge everyone to consider coming to Singapore. You don't need to go all the way to US to attend SNO. It's right in your region. And we are getting a lot of the expert speakers from both US and Europe to come and give us these talks. So we'll keep the questions to the end. So next, in the interest of time, we will transition to the next talk. I'd like to introduce Brendan Chia, who's a good friend and colleague, and also he serves in the SRS committee as well. He's a consultant radiation oncologist who was with NCC for many years, but has just transitioned to private practice with Raffles Cancer Center. His subspecialty interests also revolve around CNS tumors and lung tumors, similar to Kevin. And he's got experience with SBRT as well as SRS. But today he'll be talking to us about something different, something new that NCCS has just acquired and gone operational since last year. So he'll be talking to us about their experience with using the proton therapy facility to treat brain tumors. Brendan?
Thank you, Bala. So yes, I'll be sharing our proton therapy experience for CNS adult tumors. So this would be the content of my slides. We'll talk about the background, the brain RT facilities in NCCS, and the case studies of the dosimetric comparison, and then some closing remarks. So we started treating CNS tumors in August 2023 in our center. And how we selected for these patients basically is based on the Ministry of Health approved criteria list that was given to us. That means in general, the cost of PBT must, the cost to use PBT must be justified. So the patients should be treated with a curative intent and an estimated OS of 5 years survival. So these were the indications given by our ministry: acoustic neuromas, basal skull meningiomas, ependymomas, pituitary adenomas, chordomas, chondrosarcomas, and any locally advanced tumors undergoing concurrent chemotherapy such as grade 3 gliomas. So what's this hype around proton therapy? I think all of us have seen this. I don't want to spend too much time on this, but we all know about the Bragg peak of protons without any exit dose. We put many Bragg peaks together to create a spread out Bragg peak region, and this is where we'll treat the tumor. And then there's no exit dose beyond. Theoretically, this is what you should get, is that the tumor will be hit and there's no exit dose. So when patients see this, a lot of them like want proton therapy and they start coming to us. And then we started having 3 centers in Singapore itself, 2 private and 1 public institution, which is the one we are at. So for NCCS, traditionally, even now, we still treat using VMAT and stereotactic radiotherapy as our 2 main treatment options, and proton is what was added recently. So for our VMAT, we use variant troponin 5mm MLCs with COMIM-CT 6 Delft couch. We usually give about 3 to 5 mm margins for our PTV and use several coplanar arcs. For SRS, we use the fine leaf MLCs with exact track intrafraction monitoring, and that gives us, sometimes we can provide 0 to 2 millimeter margins for PTV. We use triple F beams, stereotactic mask, and then we can use several non-coplanar arcs. For our proton beam, it is actually pencil beam scanning. We still have 6 Delft couch and CBCT, but there is no in-room intrafraction monitoring. So there are some setup errors that we should be accounting for. And also there's the 3.5% range uncertainty. It's a bit slower than the triple F beam, and also in terms of movement of the gantry or the couch around the gantry. So we tend to use coplanar beams most of the time. And the beam angle placements are more important when you consider proton beam therapy. So I thought the best way to do this is actually to run through some of our cases that we have done, because when we started out initially, we started to do plan comparison studies with our standard VMAT techniques for two reasons. One, we want to see that it's beneficial to justify to the patient, to ourselves, and to the ministry. Second, is also a backup plan if in case the Proton machine has any problems and the patient still needs to continue on treatment. So case one is actually a sort of young patient with Coles grade 4 acoustic neuroma with 15% of hearing remnant on the right side. So mainly he uses left sided hearing. So this was his tumor. This was his tumor here. Yeah, it's a bit of pushing onto the brainstem. All right, it's about 2.5 centimeters in dimension. So on the top is actually the proton beam plan. At the bottom is the SRT plan, stereotactic radiotherapy plan. So the plan is to give him 28 fractions of treatment. So for the proton beam, we actually use 5 angles for him. And for the SRT, we had used 8 non-coplanar arcs. Okay, but you can see there's a difference significantly. You know, if you look at the dose splash, this is the low dose volume splash. If you see the coronal views, significantly very different when you compare the proton versus the SRT plan. So there's a lot more low dose splash to the brain area. So the benefit of our proton planning system we have is that you can, if you upload the SRT plan onto the system, you can see the dose difference and sort of visualize where you will actually see benefit. So for this particular case, there is benefit when you look at more of the coronal in terms of the 5 and even the 14 gray dose. There's more sparing of the supratentorial brain. Although posteriorly in the cerebellum, you may be getting more dose with using proton therapy. But if you look at the high dose regions between the two plans, actually they're very, very similar. I would say that the magnitude of benefit is actually not really seen when you use proton. So both are very conformal in this particular case. If you look at the DVHs, however, the brainstem dose, right, is more spared with the proton plan. Everything else, like the brain doses, which is this one in purple here and the dotted line here, there's less brain tissue being irradiated. Chiasm as well, significantly better with the proton plan, which is the solid line, as opposed to the SRT plan, which is the dotted line. The left cochlea, which is extremely important, which we really want to spare because, you know, we are just sacrificing the right side, is getting almost 0 doses with the proton plan. Likewise, hippocampus is also slightly more spared with the proton plan. So in this situation, we chose the SRT, the proton plan over the SRT plan. Although both plans achieve similar GTP coverage, it was more homogeneous with the proton beam plan, and there was sort of better low to intermediate dose sparing of the brainstem as well as the brain. Like mentioned, there was 0 hippocampus dose and the left cochlea was completely spared with the proton beam. So, and in this young patient age group, we tend to want to consider about the risk of secondary side effects. So we like cancers. So this is where the proton beam would benefit. So he went through the treatment actually without any toxicities at all. So as per normal, he could continue working, and the 6-month follow-up scan showed cystic changes. So just a bit about the planning system. When we go through, you look at the treatment beams that are aimed at the planet. Not all of it do not stop directly at the brainstem. Most of it glance the brainstem. This is to prevent the sort of the LET or RBE, uncertain RBE effect that could happen if we actually use incidental dose, incidental beam that sort of ends at the brainstem, which we'll sort of talk a bit more later on. So case 2 is a grade 3 astrocytoma. This patient is actually partially resected, fairly young, ECOG 0. So when she was pre-diagnosis, she was admitted for falls and seizures actually. She was actually rock climbing a lot. So she's a very fit lady. So the Proton plan is the one on the left, the VMAT plan is the one on the right. Similarly, you can see that the low dose areas are significantly more of the VMAT plan. You can see the plan difference between the two. On both sagittal, transverse, even for the higher dose areas, right? For the proton beam plan, it's more conformal than the VMAT plan, right? And coronally, you can also see the difference. So this plan, without a doubt, proton beam was superior. Okay, coverage is good with both, but you can spare a lot more brain, and the brainstem is more spared with proton beam. Everything else, hippocampus, the right hippocampus, optic apparatus, not so much because it's very close to the field. But hippocampus, cochlea, everything is great, better spared with the proton beam. So the proton beam plan was clearly better. There were a bit of concerns with regards to post-op cavity changes, some of the implants, the staples that were used, and this had to sort of be tested and taken into consideration during the planning. We did have to do a resimulation midway treatment because the cavity did change by the time of the 3rd, 4th week, but actually there was no replanning needed because this being not a stereotactic treatment, actually we still managed to get a very good coverage of the tumor without need for replanning. And the patient tolerated the treatment very, very well. This was one of our first patients that underwent proton beam. She remained active throughout the RT, even for such a big volume. And 2 weeks after that, she continued on rock climbing. Her main complaint was actually hair loss, which she was a bit upset about. But otherwise, on the 6-month follow-up scan, she remained very stable. So this case, to me, when she went for proton, I became a very strong believer in proton beam therapy. Next is case 3. This case is comparing SRT versus proton beam. It's a 68-year-old male with atypical meningioma that was partially resected. So the tumor is here, you can see quite a bulky tumor still. The plan on the top is the SRT plan, and the plan at the bottom is a proton beam plan. So he presented with proptosis and loss of vision on the left side. Okay. So you can see that proton beam is usually coplanar, and SRT we're using multiple non-coplanar arcs. This is why there's quite a bit of low dose splash in the non-coplanar region here. If you look at the high dose areas here for SRT versus proton beam, okay, you can see that actually this area here is more conformal using the SRT. But is it very important? Probably not in this age group. But if you look closely, right, this is the optic nerve where we try to spare still, do not affect the vision too much. The one on the right is the SRT, and the one on the PBT, the one on the left is the PBT. So if you look at the 45 gray area, you can actually spare a lot more tightly the optic nerve and the optic chiasm with SRT than the proton beam. So in terms of coverage of the GTV, the one at the bottom is SRT, the one at the top is proton beam. SRT, you do get a bit better coverage for the GTV. The left optic nerve using SRT, which is the bottom one, and the proton beam is the right, seems better spared with the SRT. Chiasm, similarly better spared with the SRT. Brainstem, you know, SRT in general seems better for him. Yeah. Cochlea is about the same on both, although the contralateral side, it does seem proton is better. So overall, and for this particular, I mean, for all proton plans, after the plan is done, we have to look at it through robust evaluation. That means we assess the plan given very different, many different scenarios, you know, depending on the shift due to intrafraction or interfraction difference. And so we took the robust evaluation. So this is just an example. If in all the scenarios that we have, let's say there's a 1-2 millimeter shift in one particular direction and so forth, how many percentage of it will pass? What is the nominal result, and what is the worst case scenario and the current scenario that is evaluated? So we look at all this when sort of before we approve a Proton plan. So in general, for this particular case, the plans were very similar, and it wasn't superior with PBT, to be honest with you. However, this patient was very, very inclined to PBT, and very fixed on PBT because maybe of what he heard about it and things like that. And this patient was also very educated and a family full of doctors. So in the end, he went through PBT and he tolerated it very well as well. Last case actually is pituitary macroadenoma. This case also had subtotal reception, but radiographic progression on serial scans. So we did compare SRT versus PBT as well. PBT was given 3 beams, SRT 7 or 8 arcs. In terms of low dose areas, it's always the coronal that you will see more of a greater disparity between the SRT versus PBT plan. But in terms of the high dose areas here, if you look at it closely, actually you could see that the SRT plan, which is this one at the top, is actually a bit more conformal. Like this is the G, the C, and the dose received is actually tighter using the SRT plan. And that is actually sort of pictured in the DVH as well, where the SRT plan at the bottom and the proton beam plan at the top, coverage of the CTV is good. Chiasm, proton seems a bit worse. Left optic nerve, proton also seems a bit worse. Hippocampus, even proton seems a bit worse. And the brainstem wise was also worse with the proton, which is the DVH on the top. Of course, the low dose areas like the brain and the eyes and all this contralateral eyes and things like that were better with protons. So in this case, overall, the achieved target doses were similar and all within those tolerances for the OARs. However, there was better improvements using with SRT in terms of dose conformity and even sparing of adjacent targets like left optic nerve, chiasm, even hippocampus with the SRT plan. So this patient underwent SRT instead, and similarly, no acute toxicities. So the benefit of proton, you know, there's a lot of considerations when we see a patient who wants proton because of all the hype given. It is a very good treatment technique, but it should be considered when there are stable structures. The other things to consider is that during the planning, the RBE at the M of the beam is uncertain. We use a standard of 1.1, but we will always try to avoid direct incidental beams on the OARs because there have been reports of unexpected out of target necrosis, and a lot of times they attribute that maybe to the incidental beams and the uncertainty of the LET at the end of the beam where the Bragg peak is, or just after. For proton beam, the lateral penumbra at the end of the beam is a bit bigger. There's no intrafraction monitoring for us in our proton machine. And so we have to be careful when we use couch angles because we need to be very certain that it's very stable. So we tend not to use couch kicks when we choose to use proton beam. If not, we have to give a bigger margin for uncertainty. It's more affected by heterogeneous tissues. So like, you know, the sinuses where the last case, which was a pituitary adenoma, there was a sinus there. It was post-op, there may be implants and things like that. So we have the beam angles are sort of limited by all this. And we also have to avoid glancing beams on the bone surface because they're more prone to shifts, uncertainties. And also to note as well is that the beam entry path, there is more doses there because you're using lesser beam entries, and that can result in more skin and hair toxicities in our patients as well. So for proton therapy, the viewpoints are in general, proton beam appears superior to VMAT technique. Okay, because there's more dose sparing of adjacent structures, but clinical data of superiority is still lacking. There is a phase 2 randomized controlled trial in GBM. This was by Brown and Mohan, published 3 years ago now. But overall, there was decreased toxicities using proton beam, including grade 3 lymphopenia because of less integral brain dose and fatigue. Although this study didn't really show an OS benefit or PFS benefit or any changes in time to cognitive failure using proton beam. 2 years ago, there was another study that compared proton CSI versus involved field photon RT in leptomeningeal disease. PFS and OS improved with proton CSI, and there was no significant toxicity differences. So there is a lacking of clinical data, although dosimetrically PBT is superior to VMAT technique. When we compare PBT versus SRT, there are lots of sort of dosimetric studies available, but I think, you know, it's always a balance between conformity versus the integral brain dose. And there are a lot of multiple considerations to take into account, like the planning experience, the patient experience, the overall cost to the patient or the institution or the health care costs. So with that, I'd like to end my talk, and that is basically our CNS sort of proton adult CNS proton experience in NCCS. Thank you.
Thank you, Brendan, for giving a balanced view of comparisons between photon therapy and proton therapy. So I think generally, if we go to a proton-only center, they'll always say proton is better, but I think it's always good to have a balanced view where certain situations warrant proton therapy and other situations, perhaps other techniques may be useful as well. We do have a few minutes for questions, and thank all of you for asking the questions in the Q&A box as well. Some have already been answered, and we will maybe take on the ones that haven't been addressed yet. Maybe the first question we can address to Kevin. For multiple brain metastases, would you consider, what kind of dose constraints do you consider? I think particularly it may be regarding the brain volume. Do you consider addition of all the volumes for your radiation necrosis risk, or do you consider per lesion?
Yeah, so good question. So I think if you look at a lot of the dose constraints, essentially V12 less than 10 cc's is going to be very difficult to hit if you're treating multiple lesions. I think there are a few things that you can apply. One, some people have, essentially considered hypofractionated radiosurgery for essentially multiple brain metastases. That's one possibility. The other thing is that when I deliver single fraction radiosurgery, we focus on essentially dropping the prescription dose and making sure that it's as conformal as possible. So to us, essentially the V12 less than 10 cc's is really a reflection or representation of how tight your dose follow-up is going to be, right? So when we prescribe single fraction radiosurgery, essentially we just tell physicians to focus on conformity, just make sure that essentially the dose follow-off is tight, and we worry less about what the cumulative V12 to the brain would be. But if you struggle with that, then the other option would be to just hypofractionate, which would be quite safe as well. Yeah. So the short answer is there's no good answer.
Thanks, Kevin. Yeah, it's a difficult question to answer, I must admit. There's another question which you may have addressed in your talk about, what is your cutoff for number of brain metastases? I know if you follow the trial strictly, it may be quite a low number, but what you do in practice may be different. So what do you do in your practice?
I mean, so essentially, so really, if you talk about, so the way to have this conversation with the patient is to say that essentially, if a limited brain metastases, the role is quite well defined, right? But if anything, once you start going the realm of 4 and greater, and sometimes even we attempted to treat like 10 over lesions. I think essentially the key here will be to say that essentially patients are still at risk of distant intracranial brain failures, and so they need to be prepared for further follow-up for subsequent treatments. And essentially, is there a cutoff? I think there are some studies out there, some protocols that look at volume cutoffs. I must say that those are not very easy to apply in the clinic, and really, it's there's no, you just do what you're comfortable with, and essentially, if you are going to do radio surgery for these multiple brain mets, just make sure you follow patients up closely. Yeah.
Thank you. Brandon, there's a question. You also touched on this towards the end of your talk. Leptomeningeal disease is quite a dismal prognosis, but I know that particular study reported some survival benefit. Do you think it should be included in the indications list for MOH for palliative patients?
That's a dangerous question to answer in something that's recorded. So in that study, they did give a dose of 30 grays in 10 fractions. I mean, we do give CSI proton beam therapy, and it's very well tolerated in our patients that do CSI proton beam therapy. Whether it should be implemented across the board, I think it's very patients. There's a very you must select the right patient for the right treatment.
Yeah, I think the benefit is pretty small, but like you said, the benefit is more of toxicity reduction. And really, for these patients, we don't have many things to offer them. So it can be considered on a case-by-case basis. I think maybe for patients with better PS or limited volume disease or more systemic therapy options, it can be considered. There are a couple more questions coming in, but we are running out of time soon. So maybe we'll just take these two questions. One interesting question, maybe for Brandon. For small, I think you touched on one of your cases about acoustic neuroma case. I think that was case 1. For a small lesion, have you compared SRM treatment to PBT, and do you think fractionated PBT should be allowed or used in these cases where you can reduce the intracranial dose for young patients?
For small acoustic neuroma, so far we've still given SRS. Unless there's a very broad-based contact with the brainstem, or then do we give SRT. So for small lesions, we still consider SRS. For now, we still haven't given sort of hypofractionated proton beam CNS radiation yet, because we want to have a bit more data to see what our outcomes are before we consider that.
Okay, so next question is about brain mets. I think it's quite an interesting topic, and quite a few centers are adopting this approach, particularly for large brain mets. Is the approach of staged radiosurgery. So we tend to fractionate it over a week or so, but there's another approach where you do the treatment over a month, and that 1 month allows you some reduction in the volume of the mets, and perhaps that may allow for better dose escalation and reduction toxicities. Kevin, you want to comment on that?
Yeah, no. So it's an interesting question. I think if you look at some of the data coming from North America, I think staged radiosurgery does have its benefits. I must say that I've no experience with staged radiosurgery. Our institutional practice is really to deliver hypofractionated radiosurgery to large brain metastases, and then essentially follow these patients up over time. I don't know, Bala, do you have any experience with staging?
We have done staged radiosurgery using the Gamma Knife platform for about 5 or 7 cases. So far, the results have been good, and there is quite a big volume reduction at 1 month, and that allows us to treat the same lesion. Usually, we usually use about 10 or 12 gray for the first session and the same dose for the second session. And the advantage is that the second month, if you see new mets, you also treat them as well.
And so it's 10 to 12 gray for the first stage, and then for the second one, it's actually
similar dose.
Size,
yeah.
A similar dose.
Okay. Yeah.
Okay.
So we are running out of time, but I do want to pick your brains on one particular question. I know both of you do lung cancers as well. What are your thoughts on PCI for small cell lung cancer? Do you still adopt it when the whole world is moving away from whole brain treatment? Brandon?
Yeah, so
Kevin,
Brandon, go ahead. Yeah, I was just going to say that essentially, I think a lot of the evidence that supports PCI is based on fairly old studies. I think these days, with if you're certain that this patient is going to be able to adhere to a surveillance schedule, I've stopped offering PCI in my practice. Yeah, but interested to hear what you guys think.
Yeah, I
Brandon,
agree.
do you
Kevin.
offer?
Yeah, I do offer still as an option, but I never push for it. And you know, Singapore's a small country, right? Most patients do show up in your clinic
Yep.
regularly. So I haven't done PCI for some time already.
Yeah, same here. I think if we have good imaging and regular imaging, I don't think there'll be a survival detriment if you salvage them early with some form of radiation when they do get brain mets.
Especially when you start to think about having radiosurgery even for these patients as well, right?
Yeah,
If I get relapses,
exactly.
right? Exactly. Yeah.
Okay. There are a couple of more questions, but I don't think we can answer all of them. But do feel free to reach out to the speakers after the webinar. So I just want to thank everyone for their attention and their participation, and as well as the speakers for their amazing presentations on the novel techniques for brain metastasis, as well as for proton beam and brain tumors, and also the FARO Education Committee for organizing this. Just before we close, just want to remind everyone about the upcoming ESNO meeting. Please do join us. We want to interact with you in person. And with that, we'd like to call the webinar to a close. Thank you very much.
Thank you so much, Doctor. Before
Thank
we
you.
end, can we take one more group pictures, Doctor? Can we take one more group pictures together?
Sure.
All right, I'll put it to the gallery, and everyone please open your cam and please smile to the camera. We're gonna take pictures in 3, 2, 1. Cheers. Maybe once more. 3, 2, 1. Cheers. Thank you so much, Doctor. Thank you so much.
Thank you.
Thank you so much for the panelists and the participant. We will end the webinar soon. Thank you. Have a nice day.
The seams are down.